Hello, everyone, and welcome to this event on the geopolitics of health. Sorry, I just realized that I was live on Facebook as well on the geopolitics of health in the Middle East. My name is Tiziana Leone, and I'm associate professor in health and international development in the Department of International Development at the LSE. We have an amazing panel today with 3 speakers. I know that the third speaker is slightly late and actually trying to get into the system right now. But that's the issues when you are a medical doctor and you have last minute engagements. So bear with us while we're trying to get him on. But I can start by introducing you to the first 3 panelists. So a few rules, a few notes. First of all, this event is being live streamed on Facebook right now, so can be followed right there as well. If you're tweeting about the event, which we definitely and highly encourage you, please hashtag LSE COVID-19. I also would like to thank, before we start, the people who enabled us to do this event, who are the Global Health Initiative through Chanel Nunes, who's behind the main organization of this, the LSE event, who enabled this LSE public lecture, and also the LSE Middle East Center. More information will be posted on the chat. We encourage you to post your questions throughout the panel event. We will structure the event as it follows. Each panelist will have 10 minutes to talk in general about the key issues, what they see as the key issues on the geopolitics of health in the Middle East. This will be followed by then a few questions and discussion from me and the other panelists. And then we will go for 5 minutes on to the specific of what they see are the key issues related to COVID-19 and what has been going on. Then after this, we will have plenty of time for Q&A sessions. So please post your questions, say where you're from, and then put your questions through. The chat is not enabled, but you can post this through the Q&A. So I would like to start with Omar Dewachi, who is an associate professor at Rutgers, the State University of New Jersey. He's trained in medicine and anthropology, but his work is more in general on global health, and more specifically, he has been working on Iraq. He's really interested in both the kind of human and environmental manifestation of decades of conflict in the region, and he's been looking both at the kind of the individual as well as the health system aftermath of conflict. So Omar, I'll give you the floor. Thank you.
Thank you very much for having me, and thanks for the organizers. Good morning, good afternoon, everyone. So what I'll be speaking today is really kind of a very disturbing story around the question of healthcare in the Middle East. And I'll be focusing a little bit on Iraq, but I'll also use Iraq to speak a little bit more at the regional level. In the past 3 weeks, there had been an incredible and a horrifying incident in Baghdad, which is the fire that engulfed a Ibn al-Khatib hospital almost 3 weeks ago. The hospital, during this accident, this was a kind of a recently renovated hospital that mainly dedicated or earmarked for COVID patients. The explosion that happened in the hospital was due to a kind of an oxygen leak, and it's kind of coming close to a source of ignition, a source of fire that happened in one of the patient's room, and mainly one of the patient's escorts was working on the heater or cooking food at the same time, someone else was playing with the oxygen tank, and due to that, the explosion happened. Around 80 people at that moment, at least in the first couple of days, the report was 80 people dead, 110 burned very severely. The event really is very telling. It is what I call a kind of a diagnostic event. It tells of a kind of a broader story of what I call the unraveling of healthcare across the Middle East. My work has been mostly focused on historically. I've published a book called Ungovernable Life, Mandatory Medicine and Statecraft in Iraq. And the book really tells the story of the rise and fall of Iraqi medicine, one of the regions, at least used to be until the 1990s, one of the region's leading healthcare systems. And one of the focus of that work was looking at the idea of the clinic or the healthcare as a site for understanding the building or the making of the state, or kind of looking at statecraft through healthcare. And one of the ideas that were central in this work is how the rise of the Iraqi state was very much tied to the rise and the kind of the development of healthcare system in the country, both under the British mandate and I wrote a lot about how the British confronted healthcare in Iraq during the First World War and the kind of the state building under the mandate, but also over the past 100 years of state making under different regimes of rule. And of course, looking at all of this centrality of health to the kind of the post-US interventions in Iraq. And of course, I'm not also only mean the invasion of 2003, but what preceded that in terms of the 1990s US Gulf War and 12 years of sanctions that undid a lot of Iraq's healthcare. So to go back to that event, one of the things that we can kind of see from that event that first of all, the war, this COVID hospital was full of patients, but also of escorts. So actually this was a Saturday evening at that time, there were many patients being visited by escorts and members of the family. So you can imagine that this is not necessarily an isolation hospital, but actually the patients escort were kind of freely coming in and coming out. The problem with oxygen in Iraq has been really very drastic during the pandemic. It became the oxygen tanks became the responsibility to provide oxygen tanks, became the responsibility of the patient's family to bring in these oxygen tanks to the hospital. And they are also the ones, because of the lack of the nursing staff, they are the ones who actually open up these oxygen tanks. They are kind of asked to do that kind of work rather than the nursing staff that usually is responsible for doing this work. In the renovation of this hospital, the centralized oxygen supply had been disabled, mainly to allow for this kind of informal market of oxygen supply to flourish, because there's a lot of money to be made from the sides. The renovation of the hospital itself had been mainly done in a very cheap and under no guidance. So this is a hospital that usually should be under a very important kind of and strict rules in terms of regulations and security and safety. However, the second, what you call the false ceilings, were made of flammable material, and there were no what do you call it, water extinguishing sprayers were not installed in the hospital. So the whole place was a kind of a liability for fire or all kinds of dangerous events. So what does this what does this tell us? I mean, maybe even before jumping into that, when the response to the fire, the fire department, which is kind of almost non-existent, came in, the firemen showed up in their tracksuit, and they did not even have any proper equipment. And actually mainly the patients who are the patients' families, they are the ones who started jumping inside the hospital to get people out. So you can imagine how horrifying this event was. So there are many things that one could learn from trying to understand this failure that happened at that moment. First of all, the role of the patient's family. This is not not very new. Since the 1990s, with the undermining of healthcare, the patients' families had come to take on a major role in care provision inside the hospitals. During the 90s, when I was a physician working under the sanctions, as a doctor, we noticed and we witnessed this major transformation of the provision of healthcare. So the hospital was lacking food, was lacking medical supplies, was lacking all kind of facilities or all kinds of supplies to provide healthcare. So patients, families, and escorts came in to take on that role. So the patient's family would provide the bed sheets, they would provide the food, and sometimes when the medications kind of get erratically absent in the hospital, they will have to go and buy that medication from the black market that was kind of flourishing under the economic sanctions. And in the sanctions, of course, many of you maybe know or maybe don't know, but during the sanctions, a lot of medical supplies in Iraq became under the UN dual use list, which basically prevented many medications like cancer treatment, infection control, sanitation material, all became under the list of UN sanctioned material. And of course, the Iraqi government under the Ba'ath Party also was abusing the system by showing how using that kind of failure to show that the impact of the sanctions on the populations. So over these 30 years, we have seen a kind of a major and almost irreversible transformation in Iraqi hospitals. The post-2003, we saw this form of collapse becoming more institutionalized, and this corruption in the Iraqi government, especially in the Ministry of Health, that became under the rule of a number of religious parties and militias in the country. We saw taking over of these important healthcare, the taking over of healthcare infrastructure and the monetizing of healthcare and population in favor of making more money, or a kind of continuation of this kind of collapse system, the monetization of this state failure or the collapse of healthcare. What had happened, and it's important to understand also some of the geopolitical dynamics of healthcare prior to COVID, and this is something that myself and Dr. Ghassan Abu-Sittah had been working on over the past decade in Beirut. We've been monitoring how Iraqi patients have been traveling to seek healthcare across the region. So in Beirut, we were seeing hundreds and thousands of Iraqi patients coming in every month to seek care in Lebanese healthcare systems, partly because of the collapse of trust or the lack of trust in Iraq's healthcare, the increase of the violence that engulfed the healthcare system, and of course the failure of the medical system to respond to a lot of the medical ailments that had kind of hit Iraqi society since the since the occupation and the post-occupation period. So there had been a lot of movement of patients. Iraqi patients were going to India, they were going to Iran, they were going to even Syria prior to the civil war. And what we saw with COVID is this kind of closure of these borders, and the Iraqi healthcare system, which was already kind of failing, had to deal with this kind of increased number of patients. Since 2003, there had been a lot of promises in Iraq to rebuild or at least open up or expand the healthcare system. But actually, if you look at Iraq's history, the last public hospital to be opened, like a new hospital to be built, was in 1986. So Iraq has been dealing with a kind of a collapsing healthcare, but also not a real expansion of its state healthcare system. There has been a lot of these half-completed projects since 2003, and they're mainly projects where there's a lot of money. There is a lot of money that has been spent on these systems, but they are kind of suddenly they stop, they never open, and there's millions of dollars that become involved in this process. So what I want to suggest that one of the problems, and I maybe will expand on this more in the discussion, what we have been seeing is that the hospital, with also increasing problems inside the hospital, patients getting infected with antimicrobial resistance, the hospital is becoming increasingly a toxic place. And I think this is a problem that is expanding to other places. We've been seeing also in Beirut, for example, the increasing of number of patients dying from who are admitted due to COVID. They are dying from other causes, specifically from antimicrobial resistance infections. So what does it mean for the future where the hospital becomes a dangerous place? What does it mean for the hospital to becomes really, for hospitals to become an increasingly toxic problem for patients, and how also in this context where, I mean, and this is, we can also speak about Beirut. I was hoping maybe Ghassan will talk a bit more about this, but the exodus of a lot of the doctors, something that I also been trying to focus on to show how that this history of infrastructure building had completely collapsed with the collapse of the physical infrastructure, but also with the unraveling of the human infrastructure that has been kind of leaving these healthcare systems. So I'll stop here, and I'm more happy to kind of to continue the conversations after my colleagues give their presentations. Thank you.
Thank you so much, Omar. In 10 minutes, you've given us so much. I've got tons of questions, but I'll move on to Weeam, and I hope there's definitely going to be time for us to discuss more. You've touched on so many important points, from families to the health system to my antimicrobial resistance. Wow. Weeam Hammoudeh, from the assistant professor at the Institute of Community and Public Health at the University of Birzeit in the occupied Palestinian territory. She holds a PhD from the university in sociology from Brown University. She's been doing a lot of work on population health, but mainly her role in Birzeit is to be the head of the unit on mental health, on which she's been working actually with me as well on a project which is just finished, and also thinking in terms of deprivation and how we conceptualize deprivation mainly around mental health in Palestine and in the region in general. So the floor is yours, Weeam.
Thank you, Tiziana. And thank you to everybody who's joining us today. So what I wanted to start with was kind of this question of, how do geopolitics actually impact or influence health? And I think the two areas that resonate a bit more with my work directly, but also in thinking about the region. So I think when we think about the broader geopolitics in the region, we can think about like the more direct influences on the health of populations and their well-being, broadly speaking, and then also what kinds of impacts that also, or the consequences of these geopolitical conditions on health systems or and public institutions, I think even more broadly speaking. So, and I just wanted to say maybe a little bit just kind of on the region, and then maybe I'll narrow in a bit on Palestine and touch on how some of these things are actually manifested. So I think one of the key geopolitical conditions or determinants, I think I mean, and it's not going to come as a surprise, but it's also in the region, there have been, different conflicts and wars throughout, like in the past decades, and especially, Palestine being one of them, but also in other parts of the region, and then more recently now with Syria and Yemen. So we have situations where you have like more direct impacts on health through like violence and war and destruction. But I think what I wanted to try to think through and maybe talk a bit more about was moving a bit from that focus on the more direct impacts. Is what do these conditions actually, how do they shape health, and how do they also shape health systems? And this is where we really do need to kind of look at this like broader view. And one of the key ways in which these conditions have actually really shaped health is both directly and then indirectly through their impact on living conditions, on on sort of the mundane and day to day that gets at people, and in terms of both more physical health indicators and then also measures of well-being and mental health and whatnot. And what we're seeing in a lot of places in the region is also like there is conditions have been worsening. Some health indicators, even ones where there were improvements on, they've actually gotten worse, especially if we look at cases like Yemen and Syria. And then also at the same time, it's like thinking more systemically in terms of what consequences did these wars have on these places, broadly speaking. And one of the key areas in the geopolitical landscape is kind of in thinking about refugees and forced displacement, and also and then the fragmentation that results from occupation, from war, and from these varying conditions. So I think maybe like focusing in a bit more on Palestine. So what we have is, if we're going back to the 1948 occupation of historic Palestine, and that was, the initial fragmentation where we had the West Bank as this entity that was controlled then by Jordan, the Gaza Strip by Egypt, and then you had what was left of 48 now becoming Israel. And so that was sort of like that moment where you had that initial fragmentation. And then what's happened since then is that fragmentation is actually increased. So in 1967, Israel occupied the West Bank and the Gaza Strip. So, and each of them was actually dealing with different health systems. Like I said, the Gaza Strip was controlled by Egypt and the West Bank by Jordan. And at that time, and I think this is also of relevance today. And at that moment in time, Jerusalem was illegally annexed by Israel and was further fragmented from the West Bank that it was actually a part of. And we're seeing a lot of the violence and some of these things play out, especially in a more heightened way in the last few days. But why that's significant is also in thinking about the health system that actually further removed, so residents of Jerusalem were treated differently from other people in the West Bank and in the Gaza Strip. And so you had parallel systems already coexisting. And then from 1950 onwards, you also had the United Nations Relief and Works Agency that was responsible for the health of refugees and continues to work until this day in both the Gaza Strip, the West Bank, in Syria, Lebanon, and Jordan, where the majority of Palestinian refugees are. And during that time, so during that time, the residents of Jerusalem were actually under the so they were, their health was the responsibility of the Israeli Ministry of Health, while other Palestinians were in the West Bank and in Gaza actually were under the what Israel called the civil administration, but it's part and parcel of the occupying forces. And this is where a lot of, you know, the under and this is a period of time where there was a gross underinvestment in health and healthcare. You had the separation. The health insurance was only available to people who were actually working in the civil administration. So which only covered about a third of people. So most health services were actually provided by either UNRWA or by what later became Palestinian NGOs and charity organizations that tried to fill some of this gap. There was huge underinvestment in Palestinian health, even though Palestinians actually paid taxes and were otherwise taxed by the occupying power, and despite Israel's responsibility as an occupying power towards the health of Palestinians. And just to give you a sense, the budget for the entirety of the West Bank and Gaza was about 60% of the budget of one of the second largest hospitals in Israel serving Israeli citizens. So this is, and for a long period of time, a lot, you know, that people were not really able to access healthcare. Health conditions in some areas improved with some improvements in living conditions, but this was also not really sustainable system building. And then after the first Intifada or uprising, and then when the Palestinian Authority started to take charge, they basically inherited the system that was already you know, that already had a very weak infrastructure. It was already constrained in different ways. And then at the same time, the Oslo Accords also dictated the scope in which cooperation can actually exist. So there was an emphasis on immunization, vaccination, things that would impact the Israeli population. But there were also restrictions on the kinds of services and things that could be further developed, especially with restrictions on what can actually enter the West Bank and Gaza. And this is something that has actually further entrenched the dependence of the healthcare system on the Israeli healthcare system. So during the civil administration, about 40%, between 37 and 40% of the budget for the Palestinian healthcare system that was run by the civil administration actually went to referrals at Israeli hospitals. Right now, like if we actually look at the budget with the Palestinian Ministry of Health, the figures are quite similar. So you still have about 40% of services are actually referral services. Not all of those are through Israeli hospitals, because and there's been some variety in that sense, but the biggest share in terms of cost has actually gone to Israeli hospitals. And so this, I mean, so this actually indicates that there hasn't been enough development in the healthcare system in order to meet need. But what I do want to point out is that this is also systemic. So part of the reason for why that need actually exists is because of these restrictions that are artifacts of the Oslo era. One of the key areas and one of the most costly areas for these referrals, for example, is oncology services. And the reason why they can't be further developed is because of the restrictions on what is called like dual use substances. So things like radiotherapy treatments can't actually be allowed. The siege also on Gaza for the last 14 years has completely, you know, has caused a lot of destruction to the healthcare system. So this actually has further entrenched dependence. And this has also been used politically. And there have been reports of people, for example, in Gaza, like being put in positions where they have to make political concessions or in order to actually get permits. And there have been several outcries from the WHO and others on issues related to access. But this is also kind of, yeah, and I think this is true maybe for some other places. Part of the problem is there's been underinvestment. There are certain features that are similar to other places in the Arab world, where there's been more privatization and underinvestment in public goods. But at the same time, given the ongoing occupation and ongoing settler colonialism, there's still kind of been this humanitarianism has really shaped the discourse and interventions around healthcare, which haven't really done much in terms of system building and sustainability. And this was one of the things that actually has come out quite markedly in terms of the COVID-19 response, where a lot of these systemic failures, and these are, systemic failures by design, have actually really weakened the response. Issues around fragmentation, the lack of sovereignty, working also across parallel bodies that don't really necessarily coordinate that well with one another, has really stifled the response and in important ways. And then the other thing is also just the ongoing occupation, and we saw that very markedly in terms of just the differences, for example, in vaccination and the ability to, for example, for Israel to vaccinate its citizens versus vaccination efforts in the occupied Palestinian territory that have been stifled in various ways by Israel, even though many have argued that as an occupying power, it's actually responsible for them. So I think it's also the intersection of these things has really played an important role. And what I do want to point out is, in situations, I think, where there is more active conflict, more active war, I think what tends to happen is there's more emphasis on the more emergency or humanitarian response, and oftentimes at the expense of these larger questions about what are health systems actually supposed to look like and do, and are governments actually serving the populations that they're intended to serve. And I think once we actually shift the lens a bit towards the systems that are being shaped by these conditions, and it's actually it's really important to do that in order to have any sort of sustainable impact on health and health conditions. So I'm going to stop there, and I think we'll get into a lot more in the discussion.
Thank you very much, Weeam. I can again, like with Omar, I can see lots of issues actually overlapping, but at the same time on different levels as well. So in terms of access, in terms of the structure of the governance as well, in terms of the role of humanitarianism, and yeah, lots of things to discuss later on as well. I'm going to ask all the panelists to then just see in a few minutes just to discuss the COVID more specifically, but you both already mentioned some of the issues there. And I'm really pleased that we've got our third panelist, which you can see is definitely at work. Ghassan Abu-Sittah, who is a British Palestinian plastic and reconstructive surgeon, currently in London, if I'm not mistaken, is the head of the Division of Plastic and Reconstructive Surgery at the American University of Beirut. And in 2015, he co-founded and became the director of Conflict Medicine Program and Global Health at the Institute at the American University of Beirut. He's been involved directly as a medical doctor in conflicts, which include Lebanon, Gaza, and also he's been responding to the 7/7 attacks in London in 2000, gosh, I can't remember anymore. It was 2005? Yes, it was 2005 as well. And I'll just give you the floor. I'm really pleased to see you.
Thank you very much, and sorry for the initial obligatory ID problems. So what I'd like to talk about are two issues, really. One, I think one of the things that lies at the heart of any attempt to understand the relationship between geopolitics in the Arab world and health, and the other one with regards to war and war injuries. So there seems to be something unique about the region as it came out of colonialism in the immediate post-colonial era of state building that placed healthcare and the provision of health at the heart of the state building project. And I think Omar's book really very clearly articulates the example in Iraq, but you could see this across the whole region, in Iraq, in Syria, in Egypt, and even within the PLO, healthcare was a critical component used by the state and by political elites as a legitimizing force and as a tool to gain popular support, to build a middle class that was linked to the state, and to emphasize the benevolent nature of the state and the success of post-colonialism. And so, more so, I believe, than similar experiences in Africa or even in Latin America. If we look at the PLO, the experience of the Palestine Red Crescent Society in the 70s, in the 60s and 70s in Lebanon, where by 82 and the Israeli invasion of Lebanon in 82, there are over 90 health centers and hospitals by the Palestine Red Crescent Society in Lebanon, aimed at providing healthcare to the Palestinian population there. And when we see the discourse that grew, that emerged from the first Intifada, how the provision of healthcare, the emergence of grassroots health organizations, like the health workers committees and the healthcare and the health and relief committees, really placed again health provision at the heart of Palestinian political discourse. And so over the last 10, 12 years, as we have seen, and more so in Iraq, as we have seen the post-colonial state in the region under attack and fragmenting, we have seen that how the provision of healthcare still seems to be the yardstick by which new political elites are measured with regards to governance, with regards to fitness to rule. And so we see in Iraq that the post-2003 governments were under a lot of political pressure to try to provide the kind of healthcare that was being provided by the Iraqi government before the invasion. We see in Syria that the government, despite the fragmentation of the country and the loss of military control over big swathes of the geographic area of Syria, the Syrian government insisted on paying the salaries to the health staff in Raqqa, in Deir ez-Zor, in areas outside its control, and providing healthcare for populations that live in these areas, not as a benevolent act, but because in the region, health provision is a critical component of the job of the state. And so as the post-colonial Arab state is now basically under mortal pressure and is starting to crumble, we see that its failure to provide healthcare will always be used and seen as an indicator of its failure to rule. And so I understand we're talking about COVID later on, but the kind of COVID response is one of these indicators. So I leave this idea with regards to the state building in the Arab world, even national liberation movements in the Arab world, and the uniqueness of health provision within their political discourse. Then we move to wars and war injuries. Now, what I'm about to say regularly upsets people in public health. But I believe that war injuries or war-related ill health can be classified as an endemic disease in the region. If we create a timeline of the wars in the region from the First World War to the 36 revolution in Iraq, 22 revolution in Iraq, and 36 revolution in Palestine, to the 48 war, to the Israeli incursions into the West Bank and Gaza after 48, to the 56 war, then to the 67 war, to the civil war in Jordan, to all the way to the 8-year Iraq-Iran war, all the way to the war in Syria, the wars in Lebanon, the Lebanese civil war, the Israeli attacks on Lebanon. We realized that as a timeline, this region has had a disease body that is existing, called war-related injuries and war-related ill health. And in my opinion, what differentiates war injuries from other diseases and other pathologies is that the problem with war injuries is that they carry with them the narrative of the war. Whenever you are injured by a war, you know who shot you, who you were fighting for, where you were injured, and that itself remains with the patient throughout their life. But with an ever-changing political landscape, you go from being a hero to a zero with the change of the political elite. So long as the narrative of the war that you were wounded in remains consistent with the political narrative of the political elites in the country and with the political elites that fought the war, patients were always seen as heroes, and therefore access to healthcare for their medical needs came along with it. The problems that patients have, and we can see from the kind of, this repeated wars, that we have generations of war wounded in the region across the last 100 years. What happens with these war wounded is when the narrative of their war wound is no longer consistent with the political narrative of the elite, then they are subjugated. These knowledges are subjugated and they become hidden, and their ability to access healthcare becomes problematic. And so if we take two examples, the example is the Iraqi veterans of the Iraq-Iran war, who until 2003 had available to them the best that Iraqi health system could provide, because they were the heroes of the Iraq-Iran war. Medical teams were shipped over from Germany and Sweden and everywhere to treat the wounded from the Iraq-Iran war. 2003, there's a change in the political elite, not just in the regime, and suddenly Iran is an ally and a friend, and these patients are left to fend for themselves, even though we know clinically and physiologically the aging of the war-wounded veteran continues to demand healthcare, as we can see from the data, clinical data that comes out of the VA system in the veteran system in the United States with regards to the Vietnam veterans as they're now entering into their 60s and 70s. Their needs continue. And so, and then with another example is the Palestinians in Lebanon. So those Palestinians who were wounded fighting with the PLO during the civil war in Lebanon, during the Israeli attacks in Lebanon, had available to them all of the healthcare that could be given to Palestinians. After Oslo basically relegated Palestinian refugees to a final status subcommittee that could get discussed. And suddenly they were left to fend, and working in Lebanon, I would regularly see neglected and difficult complications of wounds sustained by Palestinians in the different battles that now they are unable to get any kind of medical help for, because the narrative of the wound that they sustained in the camp wars or in Tal al-Za'atar or in the 82 invasion no longer chimes with the narrative of the current PA political leadership. 1 minute. And so the issue of the continuous buildup of these casualties from these different wars is creating a new level of inclusion and exclusion criteria for access to healthcare. And I'll stop there.
Thank you so much, Ghassan. Again, even some more thoughts. I don't know how we're going to contain the discussion here, but we try our best. What I would like to do is to now ask you briefly these are massive issues. So to just ask you briefly, what do you think is the key challenge and the key, and probably what your key idea of moving forward in terms of the pandemic crisis in the region right now? Probably I will just, it's too much to cover in a couple of minutes that you're going to have each, but just what you think is probably the key issue, the key moving forward idea. And I will start with Ghassan, so I'm going to go into a different order now.
So I think the pandemic, in the same way as Foucault described epidemics as speaking truth to the system and being a crisis rather than an event that is outside the system. This pandemic is act as if you've ever seen these structural engineers that have these machines that put pressure on the block they're trying to examine the structural strength of, so that they could elicit all of the cracks at the same time. This pandemic has done that to the health system and to the state in the Arab world. And so we see the state in front of our eyes failing in all of its aspects, whether it's the theft of vaccines by the Lebanese political elite, or the theft of the vaccines by the Palestine Authority political elite, whether it's the Jordanian hospital that ran out of oxygen at the second wave and basically its patients died, and the Egyptian hospital that had the same experience, but the Egyptian government just arrested the person who videotaped the patients in the moment of crisis, or in Iraq, the COVID hospital that had a fire and then 80 patients died because they discovered that actually the contractor had falsified the fact that they had not put any sprinklers in the hospital or any fire regulations in. So this pandemic, and what we can see in India, that the pandemic really, the real pandemic in terms of who is going to die, is beginning now in the south. This pandemic is going to hasten the fragmentation and disintegration of these failing states. And what will come out of them is, we do not know, but we do know, and this is what I want to link to what I said at the beginning, that more so than other places in the world, the provision of health is seen by the population as a yardstick by which political elites will be measured in terms of legitimacy to rule or not to rule.
I can't refrain a question actually at this stage, because the first example that I can think of there is the Palestine. What would you do in a country where there hasn't been really an election for so long, or where you know that if there is an election, you're not even sure whether it's actually going to come to fruition? I guess this question is both for Weeam and anyone. What do you do when you know that the electoral system is not going to make them accountable in the next election?
So since I'm on, and then Weeam can answer, the issue about the election was a non-starter. And the cancelling of election basically highlighted the fact that it was a non-starter. These elections were designed to where the United States and Europe wanted a clear line of succession for Mahmoud Abbas to ensure the longevity of the Palestine Authority. And the aim of this Palestine Authority is to police Palestinians on behalf of the Israeli occupation. Openly, the Europeans and the Americans accepted the cancellation of the elections because they said that, God forbid, the wrong people will get elected. And so the elections were at their best supposed to reinvigorate the Palestine Authority rather than provide real representation for the Palestinian people, which a Palestine National Council election would have done. Accountability is not part of the job of the PA that was created in '93. Security for the Israelis is part of the job. This is health and education is just window dressing for the Palestine Authority, where 60 to 70% of its budget goes to policing, and that policing is not to protect the Palestinians from attacks by settlers, but to prevent acts of resistance against the Israeli occupation. And so health is really a window dressing for a security apparatus called the Palestine Authority. And therefore, it is a miserable health system because it is just an add-on to provide a very thin veneer.
Thank you, Ghassan. Weeam, do you want to take it from there?
Sure. I think Ghassan covered part of the points, but I think I would just want to start with the whole issue of accountability. And I think it's one of the main issues. I mean, we see it in Palestine, but also in the region. And who are these political elites accountable towards? And I think, and one of the things that's actually become further cemented in the last decade or decade and a half, especially with political division, is that there's very little accountability to the general population or to the street or what and whatnot. And I think initially, initially when the PA started taking on some of that responsibility, I think there might have been more efforts than what we see now. But I mean, since then, it's just, there's a lot of underinvestment in health. There's increasing privatization, where over 40% of health costs are actually out of pocket, and this is already a population that has, poor living conditions, whatnot. The political leadership has really failed in a lot of ways, and that's also become a lot more obvious with the COVID response. Part of it, like I said, is systemic and is related to the occupation, but part of it is due to these. It's due to the corruption and failings, and it is part and parcel, like Ghassan said, of what it's actually intended to do. But I think what we are learning and what we're seeing also, as we're seeing in Jerusalem today, is I think the hope for a better future is outside of the pre-existing systems that are in place. And what we're seeing is that these gaps are actually being filled by, what are being called leaderless movements or whatnot, and that robust history. But what you're actually also seeing is like people are also actually talking about that robust history that existed in the first Intifada, that actually came in and took over that responsibility for health, for education and whatnot. And this is where a lot of the the NGOs that exist today, but they've actually been stifled over the years, this is sort of where they came out of. But the main issue is accountability, and what's being proven more and more again is that even at that bare minimum level of accountability, and you're seeing this a lot more in popular discourse, the Palestinian Authority has failed to actually act in a manner that meets the needs of the population. It's been made worse by Israel, and I think we do need to recognize that. But But I think what we need to do, especially in kind of thinking about health, thinking about even any sort of movement forward, is thinking about alternatives outside of that pre-existing system, and real accountability that doesn't actually come from the current electoral system that's set up.
Thank you very much, Weeam. I'll move on to Omar then.
You want me to answer the first question or the question about Palestine?
No, the first question, please.
Okay. So I think kind of to think about the region in the future, in the post-pandemic, I mean, there are a couple of points here to disentangle. One point is that it's very important to understand both the medical and the political as really very intertwined with each other. So any kind of healthcare rethinking about the region will require very deep political reform and a kind of an attempt to respond to many of these different ailments that has hit the region at many different levels, and including this kind of unraveling of these political systems, of healthcare systems. So we are dealing with two very interconnected problems. The burden of disease that we're seeing in Iraq or in Palestine or in Lebanon is very much linked to the failures of the political, as others have argued, the failure of political elites, but also to the collapse of these kind of infrastructures that once used to be kind of barely responding to these problems. The other issue what COVID has kind of brought in is a new form of limitation of movement across the region. This is something we kind of, I grew up in Iraq in the 70s, 80s, and the 90s. And one of the problems there that we were not able to move, I mean, you can't go to Syria because the Iraqi government had problems with the Syrian regime. You can't go to Iran because Iran was at war with Iraq. You cannot travel because no one will kind of take you in. And then what we're seeing right now, I mean, we saw some kind of an openness in terms of borders and people movement, but then now with COVID, we see kind of more closing down on population movement. So in many ways, the problem of dealing with healthcare has become increasingly more and more national. I think the future looks very grim for the region in terms of where things are going, and I think they still haven't hit rock bottom. I don't believe. I think we're just now beginning to see these kind of major crises emerging under COVID. But at the same time, I feel like also COVID cannot be also the only center of attention in the region, because people have been dying and are dying from so many other causes. And I think COVID just adds more kind of more insult to injury in these different countries. And people are being killed by the local, for example, Iran-backed militias in Iraq. There had been like 800 people who've been killed just because of the demonstration. 3,000 people have been injured. We see people dying from other conditions, even due to COVID. Maybe they enter the hospital COVID positive, but when they die as COVID negative. They die from other complications in the hospital. And I think, the financial collapse in Lebanon and the maintenance of the banks and the political kind of elites, their role in the country is really kind of a symptom that change is very, very difficult at this moment, because now everyone has become now in a survival mode, especially these political kind of ailing political regimes. The conflicts across the region has also had increased not only the local and regional problems, but there will be an increasing global problem around these healthcare issues. So to kind of come back to this issue of antimicrobial resistance, what the kind of the work that we've been doing at the conflict medicine program in Beirut and what we've been kind of writing about is how these conflicts have been a driver for the global antimicrobial resistance problem. And so this is something not necessarily being spelled out by the WHO or by Western countries. So a lot of the problems being kind of couched in the language of antibiotic stewardship, that it's just a kind of chaos and anarchy in these places that are producing these problems. But what we've been learning is that the increasing environmental problems, the pollutions, the contamination of weaponry in soil, in water, have been also pushing a lot of these stubborn infections to become really endemic in many of these countries, and specifically inside hospitals due to so many different problems. And we can kind of go more and more into some of these details. So I think what we are dealing with is a threshold at some point. COVID has kind of maybe accelerated that threshold, and if both the political and the medical are not seen as a part of the same reform process, we're going to be dealing with really long-term problems that will really haunt the region. And I think the global stage in terms of healthcare, in terms of global health, for a really, really long time.
Thank you, Omar. It's really interesting what you said about the antimicrobial resistance, and how actually the indirect consequences of COVID are even less understood now, and there could be even much more of a catastrophe in the long term. We're going to go back to this probably in the questions, but I just want to pick up on some of the points that you all three made in the initial discussion, and something that you actually mentioned, Omar, on Lebanon and then Jordan as well, and previously Syria being kind of the centers where people were going for healthcare. I mean, thinking about Gaza can't even get into the West Bank. But I wonder, in terms of the regional level, we're probably far away from getting to a stage where there is a kind of recognition of a need for a more kind of regional dynamic there. But I wonder how much this has put the weight and probably resentment in countries like Lebanon and Jordan, which we've been already overburdened by refugees. So, notwithstanding COVID, how do you see the role of kind of help within the region kind of moving forward? And I mean, I'll please do interact each other, and feel free to just unmute yourself. Omar, you seem to be ready to be first and discuss on this. Please go ahead.
Right. I mean, this has been something that I've been, writing about for a while. So at least I have a good knowledge of how to kind of articulate it. So what if you look at the kind of how, let's say in Lebanon, the reception of the kind of the influx of Iraqi patients started in 2007. When the Lebanese government have been dealing with different kind of financial crises over the years, and I think it kind of culminated over the past couple of years during the kind of the current moment of the inflation and the collapse of the financial system. But in 2007, there was a kind of a big opening for Iraqis. The Iraqis were allowed to come in without a visa, and they had to just show that they had money and they had like a bank, they had a hotel reservation. And it was seen as a way to encourage medical tourism in the country. So what you saw in Jordan, in Lebanon, in Turkey, in India, in Iran, is an encouragement of patients coming in. Of course, there were refugees, but the refugees are being dealt with through the UNHCR. Different kind of actors pay for the refugees, and be it the UNRWA or the UNHCR for the Syrians. So what these kind of systems were worried about is the kind of the income of the influx of money also coming into the system. So there was a kind of an openness to this regional, what we call the therapeutic geographies, these regional hubs that emerged in countries of less of conflicts, you know, like because Iraq and Syria were kind of erupting into these different conflicts, and people there's not only the collapse of healthcare, but also the inability of someone, let's say, living in Anbar province to move to Baghdad in 2006 to 7 to seek healthcare in the capital. It was much easier for someone in the western province to go to Syria or to Jordan to seek healthcare because of the dangers that might happen, that one could incur in traveling to Baghdad. So there, in addition to that, the humanitarian agencies like MSF also capitalized on this idea of regionalization of healthcare. The unique reconstructive surgery hospital that was established by MSF France in Jordan, Amman, was actually mainly geared for Iraqis were injured in the kind of multiple explosions that were happening in the capital, the American counterinsurgency operations, and it's a unique system of surgical care that was developed by MSF in Jordan. And with the unraveling of the conflict in Syria and in Yemen, that hospital became again another regional hub. I mean, originally, like MSF couldn't work in Iraq. So they said, let's open a hospital in a safer place in Amman, and we can bring the patient in. But then with Syria's conflict erupting and with Yemen, you began to see more patients from Yemen and Syria kind of joining that list of patients who are being treated at this hospital. In Lebanon right now, this idea that Lebanon was this haven for medical tourism is now collapsing. A lot of doctors over the past couple of years since the explosion and the financial crisis have left, and I think maybe Ghassan could also speak to that in a much more kind of personal experience. And so we've seen that, you know, places like Lebanon, which used to be relatively advanced, let's say, quote unquote, in terms of its technology, healthcare facilities, these different hospitals that are available for, you know, more advanced kind of up-to-date work is failing. Jordan, and you see all these different healthcare systems being burdened by the pandemic, are also unable to, let's say, receive patients from the region. And with travel restrictions, we are seeing that also it's not becoming a possibility. So what we saw, I think, over the past decades is this kind of rise of regional care that during these conflicts, where you see the importance of regional hubs and what we've been calling these therapeutic geographies in providing care. But now kind of they're waning down. They're kind of more closing down within the national border, where patients, healthcare the politicians and the policymakers need to now respond to how I can deal with a semi-closed borders. How can I deal now with a population with an overburdening healthcare within the population? From the Iraqi side, the funding of patients to go abroad was also another very corrupt network of system where people would be, where these kind of politicians or doctors would go to these regional healthcare and take commissions to bring in patients into these regional hospitals. So it is really unclear. I think we're kind of going through this uncertain moment where even these informal systems of travel and healthcare provision that kind of emerged under these kind of ecologies of conflicts and war, we are now seeing kind of a reshuffling of that moment and a need for something else to emerge. Maybe this will push these kind of national healthcare systems to act up and to do something. But these also could be another example, as I said earlier, it could be just another layer of misery that has been kind of being added now to the unbearable kind of life that many people are dealing with and across the region.
Thank you, Omar. Weeam, do you want to add to this, or any other thoughts on?
I think Omar covered it. So maybe.
Okay, thank you. I think we lost Ghassan briefly. So I think what I'll do now is to move on. I've got lots of more questions. I mean, even mentioning just the workforce, which I know within countries, but I'll try not to be too selfish with my questions. And I'll move on to some of the questions online. I've seen, thank you, that you've mentioned, you've answered a few already. I just want to tell Susan, I'm sorry that if this is distressing you. I hear you. In terms of your question, why aren't we getting this information in the United States, or have I just missed it? Probably, well, you've lived in the US, Omar, you live in the US. Is it true that probably some of this information is missed in the US?
I mean, if you don't mind, I'll go first. Yes, I think so. I think there is something very, I would say, very traumatic for that has happened since 2000. I mean, maybe it's been there for a long time. Of course, one aspect, at least with Palestine, it's the vested interest in the maintenance of the Israeli state and the kind of this unconditional support to the Israeli government, and so this is definitely very clear. But I think with Iraq, it's a very interesting problem because, you know, Iraq was in many ways, has become the main, Iraq and Afghanistan are the main trauma for the United States in the 21st century. The invasion of Iraq was a failure. The invasion originally was like a big lie, and then it's a failure. And then the idea that, oh, now we're done our jobs, you know, and now Biden is going to be withdrawing the troops from Afghanistan. And before that, Obama had kind of withdrawn the troops from Iraq. It's almost like everyone thinks that this is like it did not happen, or you don't necessarily want to think about it. There's something very kind of it becomes very repressed about the invasion, these long histories of interventions. And now when people speak about Iraq, they speak about it as if this is something, oh, you know, the civil war, the conflicts, Sunnis and Shias, the Kurds, you know, you get a kind of a dilution of that history through a narrative that is ahistorical. So I think one of the things is that this unfathomability of Iraq has been very central in the American public consciousness, and the inability to articulate one's own implication in that has been something very present and surprising. And of course, as an Iraqi living in the US, I always try to bring this up, you know, I mean, to kind of, if I want to stay in the more psychoanalytical language, I become like the return of the repressed. You know, every time I mention this, you're bringing these issues again and again, and people don't know what to do about it. I mean, this is where it becomes really fascinating, and people ask me what could they do, and I say, well, I mean, I'm not really sure what you could do. This is your country. These are your governments. You should know better what to do about it. So I think what we've seen, I mean, this is also a classical story of the kind of the psychology of empire, where you're doing all of this, but you're kind of almost either clueless about it, or you just don't want to acknowledge it. You're more concerned about very distant historical issues, for example, but you are unable to deal with immediate present-day events. So the destruction of Iraqi lives, for example, that has been going on for 30 years is not necessarily a platform for thinking about social justice in the United States at this point, for example. So or the kind of the what has happened in Afghanistan or elsewhere. So I feel like there is something very troubling about this inability to see the present and to see yourself implicated in the present. And you know, I mean, I really can't really say more than that. As an academic and as someone who's been kind of working on healthcare in the region and have been writing a lot about what the US has done across the region, my role has been really to kind of keep these things alive and write about them and just show how that history continues to haunt the present, not only in terms of the psychological element, but in terms of the realities and survival of patients and of healthcare systems and of doctors and the kind of the struggles of what this long history of conflict and war and intervention had produced in across the region.
Thank you, Omar. Weeam, do you want to add to this?
Yeah, what I just wanted to add was like part of it. I mean, like Omar said, it's just the sort of the lens or the frameworks and the tropes that are often used to actually think about some of the things happening in the region are, you know, some are like very clearly Orientalist or irrelevant, and they detract the conversation from what's actually at hand. And there's, and sometimes I think there isn't as much interest in trying to understand the nuance. And I think part of it goes back to what I might mention, because I think part of that also requires that you think about the US's role and its own complicity in in creating the conditions that we actually see across the region today, or being at least part of that cycle that perpetuates them. And the other thing is, there's also active silencing, like on various issues. And I mean, this is maybe more pronounced when it comes to issues around Palestine, although like recently there have, you know, I think there is still more space than existed maybe 20 years ago. But you do see a very active and also very organized silencing of, like, for example, like oftentimes people that speak on Palestine are met with accusations of anti-Semitism, and they're, you know, and typically like ungrounded, but it just detracts a conversation and it takes it to a different, it takes it to just, yeah, in a different direction that's not necessarily very productive. And the other thing I think we're dealing with also now is just, with like social media and with other things, it's like you need to get everything into these short sound bites, which isn't always very, you know, it's not possible if you're really trying to understand history thoroughly. So I think this is another challenge that we have to think about, and maybe think about alternative ways of communicating.
Yeah, and I mean, 2 points there. One is that I wouldn't say that is that necessarily an issue in the US only. I mean, I can see that even right now in the UK, the way that the problems in East Jerusalem are being reported, sometimes there is this kind of urge of doing things neutrally, and people are not really being explained why, for example, moving the capital and the embassy, the US embassy to Jerusalem is an issue. For example, many people couldn't see it. So I can't see that. And as Omar said, I mean, is anything, you shouldn't ask somebody from the Middle East of asking what we should do better. It's a question of what we should do. It's the same thing that we would say with the Black Lives Matters. Why are we asking people of color to actually be the people who are responsible for us for actually taking a stance or having more information? So I think that's all related to that. Sorry, I've got 10 minutes and we've got a few more questions, but I want to link one question from Facebook, and I think Ghassan now is back online, so I want to take advantage of that to move on to the workforce and within the health systems, and also relate that to the region, if I can kind of make a Uber question there. The question from Facebook was on what about the medical aid, retention of medical aid to Iraqi Kurdistan for the IDPs who are seeking aid from Syria and the Christian minorities. I would like to extend that more in general on medical retention in the region. And also when I was talking before in terms of trying to go for this kind of regional planning, I mean, one thing that is definitely obvious, for example, in the Palestinian territory and general in the region, is that we haven't got that kind of retention and planning that we need. And that's where one of the failures of the health system as well. So in general, Ghassan, probably if you can, if you're there and can speak,
Yeah.
whether you can talk more around the issues of the workforce.
So if we want to chart the history of workforce development in the region, in Iraq, and Omar can speak much more eloquently about this, because this is really the body of what he looked at, but also in Syria and in Palestine. We had a phase of growth in the immediate post-colonial era, with the production or the mass education of health workers in the medical schools of Cairo, Alexandria, Damascus, Aleppo, Baghdad, Mosul, and Basra, which produced thousands and thousands of health professionals, and similar in the nursing schools. And then you had the reversal of a lot of these achievements, as you know, from the 80s onwards, as the wars started to take their toll. World Bank-led economic policies, so in countries like Jordan and Egypt, where a lot of the destruction of the health system that was built in the 50s and 60s was not as a result of war, but as a result of World Bank-driven policies to reduce the provision of free healthcare. And so all of these policies have led to, one, the migration of thousands and thousands of nurses and doctors to Europe and North America, and transitionally through the Gulf states. But what that has then led to, and we could see this in Iraq and in Syria. So what you had is that these medical schools still produce doctors, but that the infrastructure for postgraduate training has disintegrated. And so we are still producing thousands upon thousands of Iraqi medical students through the medical school, but none of them are actually able to receive the kind of postgraduate training that has helped the health system evolve in previous phases. In addition, you know, Fortress Europe meant that a lot of the trainers that had basically become trainers by traveling to the United Kingdom or Ireland or France or Germany, and then returned to build these health systems in the 60s and 70s, you know, Fortress Europe meant that there was no generation that would travel. Now, the interesting thing is some of this gap is now being filled by the Chinese. And the Chinese are now offering postgraduate training to Syrian and Iraqi doctors and to Palestinian doctors in the same way as Western governments were in the 50s and 60s. And so the lack of retention as a result of the impoverishment of the middle class, or as a result of the wars, still is creating a kind of distortion where the picture is much worse than the statistics will suggest. The statistics will tell you how many doctors there are per thousand population, but in reality, a lot of these junior doctors have not had the ability to receive decent undergraduate education or to receive any postgraduate training.
Thank you very much, Ghassan. Anyone else wants to add to this?
Sure, I can jump in. I think it's very important, again, to, like Ghassan was saying, to see this also again through this kind of lens of history. The NHS in Britain, for example, which was established 1 year after the retreat of Britain from South Asia, was a kind of a promise of national healthcare, and of course that system began to fail in the 1960s, and the response to that was to call on Indian doctors and from the post-colony and all these different doctors where Britain had kind of occupied to come and save the NHS. And that's what happened in the 60s. This is all was done under the government of Enoch Powell, and so which is the conservative politician. And over the decades until the 70s, many of the doctors were there was less incentive. Maybe there was more incentive for doctors to be sent from, let's say, Iraq or other places to the UK. And some of them would be trained and then come back to their own countries as part of nation building projects. This with the development of the EU, and now with the collapse of the Britain's relationship with the EU, this has all been changing. So with the involvement of Britain in the EU, a lot of these overseas doctors that have kind of supported the backbone of the NHS from Iraq and from India, from Pakistan, Bangladesh, even Egypt, were kind of let go. They were like, you don't have a place now. We can't give you visas. The priority became for more the European doctors. So that was a kind of a one main betrayal for this history. And then what you get after that is more, at least in the Middle East, the scrambling of doctors to figure out other places to work. So as Ghassan mentioned, people went to the Gulf states. People try to figure out other kind of possibilities, go to maybe even the US, but even the travel and the movement of doctors has been very, very difficult. What we're seeing right now is a kind of first of all, a lack of also any kind of medicine as a social movement. Like what we're lacking is we're unable to see doctors coming together to create a new platform for political, social, and medical reform. This is something maybe happened in other places in the world, in Latin America, in the Nepal under the 90s revolution. So we saw that the important role of doctors in these kind of different historical moments. This is something we are not necessarily seeing in the Middle East. And I think one way to think about that retention is if you give doctors a good reason to stay. That is not necessarily that training doctors are not only about training them in the medical skills, but training them to really respond to these kind of more broader political ailments and social ailments of society. This needs to become something much more central in thinking about broader conditions of political reform. Not that I'm calling to medicalize society, and I know, like, I come from that whole literature of biopolitics, but I think in many ways we need more biopolitics. In many ways, that's the whole problem. I mean, I sometimes confront scholars writing about the region, and they're throwing these biopolitics here, biopolitics there, Foucault here, Foucault there. But actually what we've been dealing with is this collapse of that kind of system of governing and ruling through health, but rather we've seen this kind of collapse of healthcare across the region. So the retention of doctors has to do a lot with with how political and social reform are going to be envisaged and who's going to make that. There's been a lot of mobilization, but they are very weak and maybe scattered across Iraq. There's been an ongoing revolt happening since 2019 and even before that. In Lebanon, there has been some kind of an uprising, although they are very weak and very scattered, and they're not necessarily have a very clear idea, but these might be beginning of a longer process. And I feel like doctors and healthcare professionals have a very strong and important role in some kind of creating a narrative of reform that is about the healthcare system, but it's also about the physical, the social, and the political body in many of these societies.
Thank you, Omar. Lots of really interesting points. I mean, in my head, I've actually got ideas for another 5 seminars involving 3 of you and more. We have to wrap up, but I want to give the last 30 seconds to Weeam with one last question, because otherwise I've been a bit too totalitarian in the way I've answered the questions. The main question is basically, what do we need to see in order to finally get a proper Palestinian health system? And you've only got 30 seconds, so that's peanuts, really.
So I think I would, what I do want to stress is the issue of accountability. So I think there's a need for greater local accountability in terms of the pre-existing system and resources, but then there's also a need for holding Israel accountable to its obligations, and also holding the international community accountable for like a more for a longer term and more just solution to ending the occupation and ending all the political, the factors that are actually adversely affecting health and the health system more broadly.
Yeah, because I mean, one thing that we didn't really touch upon, and yeah, that would be another hour and a half of discussion, is really the kind of community level versus the I mean, yes, the state is missing. The Palestinian Authority has probably failed the Palestinian population, but there is a lot on the smaller level going on, and probably building on that.
Yeah, I mean, I think there is some that we're starting to see a resurgence of that, but I think part of the negative consequences of Oslo is that there has been growing authoritarianism that has actually demobilized the population, and others have written about that. And I think that's also had impacts on even health and health movements. But I think this is, if we're going to actually see change, it really will need to be back in communities and back in sort of people pushing for more equitable systems across the board.
Thank you so much to all the three speakers. It was really nice listening to you. And I know there were a few people that said, this is too fast, too many things happening all at the same time. The good news is this is being recorded. And actually, I think I need to even go and listen to it myself again. Please do follow the Global Health Initiative and the Middle East events online. We've got more of these coming up. Thank you very much, Omar, Ghassan, and Weeam. I hope to be able to, at some stage, to meet up with you and have a proper chat around a cup of tea. So from us, thank you very much, and until the next event.
Thank you.
Bye.